going to talk about DVTs and their risk factors or possible causes. So they fall into three categories. Trauma is basically its own category. There's different types of trauma, that can cause a DVT. But in your other category, you have a change in your blood flow. And so that has to do with stasis mostly, if the veins are not moving things through. So if you have some sort of condition that is inhibiting your blood's ability to move. And then we have our hypercoagulable states, or a change in our blood ingredients or blood components. Okay, so now we have our hypercoagulable states. So medication, the number one medication that kind of increases our hypercoagulability is hormones. So some sort of hormone therapy, whether it's with birth control for females, it's usually the estrogen component that puts you more at risk for having a clot. And then for males, testosterone puts you more at risk for clotting because it increases your red blood cells. Okay, then now we have our inherited problems. So usually those are our inherited thrombophilia problems, something in the clotting cascade itself. So now you have an inherited trait that makes you clot more. One of the more common ones is factor V, Leiden. And I think it's spelled that way. So in factor V, Leiden, you have a mutation, and there's several different types of factor V Leiden in severity, depending on which trait you inherited. But it has to do with the fifth clotting factor. So they make more clots than they should. Okay, now our other hypercoagulable states would be our malignancies. So if you're growing a tumor, not a baby's a special kind of tumor, right? That tumor you get to take home. But a malignancy, a real tumor, is growing something at a very, very fast rate. So those cells are dividing, multiplying really fast, and they're not stopping. And so because they're multiplying, dividing so fast, we could suppose the reason why we might be at more risk for clots is because they are making and breaking down more clot as well. Okay, now the other bit for hypercoagulable state is being pregnant. So when you're preggo, your body is creating and dividing and fastly multiplying cells in the baby. We're creating things at such a high rate. So we're making organs, we're making bone, we're making skin. And so in that process, you're breaking and making clots a lot, okay? Then our old people, the DVTs favor the old people, obviously, okay? So as you get older, your risk for a DVT increases dramatically above the age of 80. Obviously more above the age 60, but much more over age 80, okay? So now we have our static condition, right? The other side of our triangle, our change in blood flow. And several things can make our blood flow kind of change or slow down. So the first one is a post-op or post-O. And usually the window when you're at risk for a clot the most is in a 3-week period after your surgery. So 3 weeks post-op. Then during surgery, we're not moving around, right? We're laying there. So depending on how long the surgery is, so peri-op puts us at more risk, and the anesthesia drugs as well. And so then we have preggo. So we got post-O, perio, and preggo. But preggo is up here. Yeah, you got two problems. So when you're pregnant, you're making and breaking more clot, but you're also in a static, your blood flow is kind of in a static position. So so pregnancy has two parts of that triangle. So when you're pregnant, don't get in a traumatic accident, right? Okay, so then we have also postpartum. And usually within that first 3 to 4 weeks, immediately postpartum is when you're at the greatest risk of a DVT or a clot somewhere. And so, that's why we are kind of hyper aware in those periods and times. Okay, now we have potato. So we got post-O, perio, preggo, post-po. got potato, comma, couch. Well, what's that? Well, that's the fancy way of including all, making them all P's. That is immobility. So if you have some sort of diagnosis where you are immobile now, whether it's a chronic illness, some sort of immobility diagnosis, paralyzed, whether you're paralyzed, limb fractures that keep you from being mobile, so then it puts you more at risk, okay? Then we have travel for greater than 4 hours. So if you're on a long car ride greater than 4 hours, or a plane ride, any sort of traveling where you're just sitting for 4 hours, you want to make sure you're getting up and moving every hour, or at least doing, calf stretching, that kind of thing to keep the blood moving. And that's why they say wear compression hose when you're traveling, things like that. Now, sepsis has its own little category. That's why it's not on the triangle, because during sepsis we are making and breaking a lot of clot, and so it does put you at risk for a clot somewhere, specifically DVT. Then if we have a trauma, so if we have some sort of vascular trauma to our tissues, particularly our limbs, right, because that's where DVTs usually are, so particularly in our limbs, then we are at increased risk for clots, because when the tissue is insulted or injured, then now things are going to be trying to repair that, including our clotting factors. Okay, and then also if you are a smoker, over a long period of time, you're causing little micro traumas to your venous system, and so you're at increased risk for a blood clot in your leg or arms. And okay, so now let's move to the second half of the board. Now, the next thing is, what are our signs and symptoms of a DVT? Okay, so usually people complain in our subjective finding column. What they complain of is they complain of pain in the extremity, right? They'll complain that it feels hot or warm. So it might feel warm or hot to the touch. They might complain of some swelling, okay, in that limb. And then it might also be red, some sort of color change, right? Now we have, but usually red. So now we have our objective findings, things that we can observe or find on an assessment. And so, yes, it is tender to palpation, usually. So it usually is tender when we try to touch it. The objective version of swelling is edema, right? So you push on it, and then your finger indentation is still left in there. And depending on the grade of it, sometimes it can be as much as 3+. All right, then, well, the medical version of redness is we might report some erythema, so some redness. And then also we can feel the warmth, or it might feel hot to the touch, okay? Then also, you might see and probably see a difference in diameter from calf to calf or arm to arm, if that's where you're looking. So when you go to measure the widest part of the calf, and you might see your affected leg, the one that's symptomatic and hurting, might be larger around than the other, okay? Now, if we suspect a DVT, we need to do a few things, and this goes for any time anybody has a complaint in their limb. We need to assess some things, okay? So included with this, we also need to check a cap refill. We need to check a pulse, okay? And distal, obviously, to the problem. We need to check sensation, mobility. So just make sure if you're looking at their leg, at their lower leg, make sure they can wiggle their toes, that they can move the leg, how well they're able to walk on it, that they have feeling in that leg. So this is abbreviated with our CMS. So our circulation is verified with our cap refill and our pulse, and then our motion and sensation. So mobility, sensation, and circulation. Then we also want to ask them, when did it start? So you want to know a duration. When did this all start? right? And then what were you doing when it started? All those good PQRST questions, right? What makes it better? What makes it worse? Okay. All right, now let's talk for just a second about Homans sign. So Homans sign was an old thing, and it's not that old because I remember it coming out of nursing school. We used it for quite a long time until recently. So Homans sign used to be you would have your patient, your freshly post-op patient, every shift you would have them flex, dorsiflex. You would have them dorsiflex at the ankle. So point to themselves with their toes if they're laying in bed, okay? And if it elicited calf pain in their calves, it was considered a positive Homans sign. However, if you can think critically through this, there are millions of things that could make you have calf pain, right? If you just worked out at the gym, if you are a little bit electrolyte deficient, then you might have muscle cramps. You know, your potassium, calcium, magnesium is not great, and sodium as well, then you can have muscle cramps when you flex your leg, flex your foot. So you can see how this can be a very sensitive test, right? Because it can be positive in all sorts of circumstances, right? Also, if you have a DVT, it could possibly be positive. Now, it's a really low specificity because just because you have calf pain when you dorsiflex is not specific to just a clot, okay? So that is the reason we don't use Homans sign anymore. It is not reliable, okay? All right, we'll go to the next bit. There's a few things that we want to do to prevent the formation of a DVT. So we want our people to walk, want them to ambulate. We want them to wear compression socks, compression, to prevent a DVT, usually in the 30 to 40 millimeter range of pressure. They have them wear STDs immediately after surgery. So those are the little Velcro things that go around their whole lower extremity. And you hook them to a machine, hit the button, and it cycles kind of like a passive massage a little bit through there. And then we also give them lovenox or heparin to prevent. And now, a little side note on STDs. If you come upon your patient, you know, anytime during your shift, and you notice that they are highly suspicious, that their symptoms, objective findings are highly suspicious of a DVT in one of those limbs, you do not want to put those STDs on that affected limb. Okay, make sure that you keep it on the one that is not affected. Make sure you let your provider know that you've removed it, and then let them know that they have a change in their status and that you suspect a DVT in that leg, that affected limb. If you are the provider, just make sure that you are ordering those STDs only on the unaffected limb, because we don't want to massage that clot and possibly move it, because then it would go up to the lung first, right? So we don't want to do that, okay? Now, ambulating post, so now this is after we've been diagnosed with a DVT. So this is kind of our prevention, and this is after we've diagnosed ourselves, or we've been diagnosed with DVT. So we ambulate, we wear compression socks at 30 to 40 millimeter, just a kind of a reference point. The ones that you find that are kind of the fashionable ones with fitness, and the cute ones that nurses wear, though, and healthcare workers wear, those are usually 15 to 20, sometimes 20 to 30. However, if you want the 30 to 40, you have to sacrifice fashion, because it's pretty impossible to find the cute ones that go 30 to 40. So if you want to be serious, you got to just get the regular plain colored ones, the black or the white. And you can get them thigh high or knee high depending on what they want. Now, they usually have you wear them if you have a DVT for 1 to 2 years, but they may extend that just as prevention from making more, right? And then there's also surgical interventions that can be done. There's clot retrieval. They can place an IVC filter in the inferior vena cava to catch any clots that might be forming and then trying to go somewhere bad, right, to the lungs. So there are those things that help. All right. Treatments for a DVT. So the preventative dose for lovenox, that is different than the treatment dose. So the preventative dose is usually half of the treatment dose, and the treatment dose is usually 1 milligram per kilogram. So you'll see lovenox prescribed to them on their orders, but that doesn't mean that they have a DVT. So you have to look at the dose to decide, is this a preventative or is this a treatment? Okay, so for treatment, usually for the first 5 to 10 days, we give lovenox subcutaneously, so sub-Q. And it usually lasts. The advantage to lovenox is that it can be quickly undone, relatively quickly, right? Because it only lasts for 12 to 24 hours at the most. So that's why you'll see it being given BID or Q day. So you might see it being given twice a day or once a day. All right, now heparin we do for 5 to 10 days as well, and you can do it sub-Q, okay? Or you can do it IV. So sub-Q, they'll keep them on it a little bit longer, but that dose is dependent on their PT, PTT, and their weight. So it's very weight dependent and also on the results of their PT, PTT. So now, when we're giving it IV at onset of diagnosis of a DVT, then we give it IV push, a bolus dose. So that first dose is usually a bigger dose than the drip that follows after. So they get a bolus dose IV push, and it might be anywhere between 3,000 to 5,000 units IV push, depending on their PTT and their weight. Then we immediately, as soon as the bolus has been given, whether you give it from the bag in a drip form, you give the bolus drip over like 5 minutes, or you can give it from the vial, IV push over 5 minutes. Now, we usually coordinate it in a drip, IV, and then usually it's at a lower rate. So if they gave them a 5,000 unit bolus, they may give them, depending on their PTT, PT and their weight, they may calculate a bolus or a drip dose anywhere between 1,000 units an hour up to 1,500 units an hour. Or even greater. It just kind of depends on their lab results and their weight. Okay. So usually this needs to be set up prior to coming into the room, and the pharmacist usually prepares the drip and sends it to you. And so the reason why a lot of places don't give the bolus from the drip is because we need to give them something right away, and most floors and units will have heparin in a vial that you can just draw up and give for your bolus so that you can get them going on some sort of anticoagulation. Okay? Now we have warfarin and coumadin, or warfarin or coumadin, which however you want to call it. It is given by mouth, and it's usually a long-term solution. So these are kind of more short-term treatments, and then these are more in the long term. This one's more the long-term treatment. Okay, now, so it is given by mouth, but it takes 4 to 5 days to get up to where you want it to be, and we measure it with the INR, that international clotting ratio. And usually we want it to be that INR, we want the INR to be between 2 and 3. Some coagulation clinics want it to be between 2.5 and 3.5. So it just depends on who your provider is and how closely or how much they want you anticoagulated. All right, so that's how we monitor their how well the medication is working. Now, coumadin, warfarin, they have some serious disadvantages. It's a great medication, but it does have some disadvantages in that it conflicts with so many medications. Okay. The other advantage is that your INR is very person to person dependent. So I could be taking the same amount of coumadin as you, and then we go get our INRs checked, and they might be completely different. Why is that? Well, the reason is because everyone's intake of vitamin K is person to person dependent, depending on how many vitamin K rich foods you're eating, like leafy green vegetables and a whole list of other things. So then it also conflicts with many medications. We've got antibiotics. We have so many meds that it will either, the medication will increase the warfarin or decrease. And so Either it's going to increase it, which then puts them at a risk of bleeding, or it decreases it, which now then they're going to be at risk for a clot. So it's a bit of a balancing act that you have to play. It does last for 4 to 5 days. So if you want it reversed, you can't just stop taking it, right? Okay, now depending on what their INR is, well, let's talk about the mechanism. So it inhibits vitamin K, and we all know that vitamin K is a cofactor, right, in the liver in the production of 4 clotting factors. That's huge, right? So that's why it's such a potent anticoagulant, because it inhibits 10, 9, 7, and 2, okay? And if you can't remember, it's 1972. So think 10, 9, 7, 2. Get rid of the 0, 1972. Okay. So now, if we give them vitamin K, let's say they come into the ER, they have some sort of bleed somewhere, either from an injury or a nosebleed. That's one of the most common ones. They'll present with a nosebleed that won't stop. They will be given vitamin K. Now you can give it IV or sub-Q, or sorry, IV or IM. That's vitamin K, IV or IM. But it only lasts for 12 to 24 hours, that dose. So you have to either keep giving it, or if they're continually bleeding, it's not stopping, and their INR is greater than 8 or 9, or sometimes even 6 in these cases, if the bleeding's really bad, then they will be given fresh frozen plasma, and that will permanently reverse any sort of anticoagulation that was going on. So the fresh frozen plasma contains clotting factors, right? Well, we weren't making clotting factors, so then you give them the clotting factors, okay? All right, so that is coumadin, okay, or warfarin. Now we have our another oral medication that are becoming a lot more popular because they don't conflict with a lot of different medications. You can give 1 dose and the amount of anticoagulation is the same. We have our factor 10A inhibitors, and those are kind of the newer ones, they all in bands. So xarelto, eloquis, and savaysa. You can reverse them with Andexa, and that's usually given IV, or I'm sure there's other routes now that it's available in. And then there's the direct thrombin inhibitor, and that's just one, and that's Pradaxa, ends in the tran, okay? And we give Praxbind to reverse that. Now, one quick thing, if we have a DVT that is distal, and you have a DVT that's proximal, more proximal to the center of the body, which one is more likely to travel and become a PE? Well, it's simple, right? I just wanted to make sure everyone understands that if you have a more proximal DVT, so a DVT in your thigh or your upper lower extremity is going to be much more likely, or increased chances of it floating and turning into a PE rather than a DVT that's really distal, okay? When we have so let's see, our worst case scenario for any DVT is that it will travel to somewhere bad. And the first place that it hits and get lodged in is in the lungs, the pulmonary system, okay? So that brings us to the emergent, kind of really quick, hard right heart failure, but more aptly named cor pulmonale. So cor pulmonale is an alteration in structure or function of the right ventricle, okay? And it's usually caused primarily by a disorder of the respiratory system. Now, a chronic example of that would be COPD, right? And then an acute example of cor pulmonale, where it comes on suddenly, would be a really large pulmonary embolism. Those ones that are sitting right there in the pulmonary artery, okay? So, and they're big, they're occluding the entire vessel, so nothing can get past it. So then what happens is you have an increase in right ventricular size, because the right ventricle is trying really hard to overcome that clot and push past it. And then we have an increase in afterload, then we have an increase in pulmonary resistance suddenly. Then our right ventricular output is crap, right? It goes down like a clown. And then now we have our left ventricle output is crap. because the right ventricle is not giving them anything. So if the right ventricle doesn't give them anything, it's going to be low, which means our cardiac output is going to be crap. Okay. Now, if you think back to a week ago in Megacode Week, what was one of the reversible causes of pulseless cardiac arrest? And if you think about the H's and the T's, it's one of the T's, and it's a thrombosis. So if you get a big enough thrombosis, remember in one of those three places, lungs, heart, or brain, then you can have pulseless cardiac arrest. Okay? Explode your brains a little bit? All right. Okay, then we're going to go to our next. A few symptoms of acute core pulmonale. So whether it's caused from a PE, we're going to go on that thread today because that's the thread that we're kind of working under. So your immediate signs and symptoms, they're going to feel fatigued. They will feel incredibly short of breath and dyspneic, right? They're going to have horrible chest pain. Now, that chest pain doesn't necessarily respond to nitrates. So they may just present to the ER with chest pain, but we don't know. It could be a PE, it could be an acute MI. So, you know, we give them nitrates, but it may or may not respond. Usually doesn't respond to nitrates. And that's because it's the pulmonary artery that's stretched, okay? And it's not a muscle, not a heart muscle ischemia issue. And so the nitrates aren't going to help. They won't help with the actual root of the problem in this case, which is the pulmonary artery that's overstretched. So then we have a change in our vital signs, and you might see them trending this way. So it might not be, you know, all of a sudden. It might be over, you know, 15 to 20 to 30 minutes, maybe an hour. So their heart rate's going to start to increase, right? Because we're trying to pump to the heart harder because we're deprived of oxygen. We're not getting any perfusion. And then our respiratory rate's going to be high to try to increase the amount of oxygen we're getting. And then our blood pressure is going to be high, and then our O2 sats are going to start to really decline. So their oxygen demand will start to increase, and you'll all of a sudden have to start turning up their oxygen or put oxygen on them. And they didn't come with oxygen, and they were previously perfectly fine without it. So yeah, that is a big indicator something's wrong. All right, now, kind of a side note, special little fun thing if you want to be super extra smart. I've never seen a provider do this, nor have I ever done this, but you can see if the PE, if the pulmonary embolism is big enough, you can see it on a 12 lead EKG. Now, normally when someone has chest pain, we get a 12 lead EKG because we're trying to make sure it's not an acute MI or a left bundle branch block or, you know, some sort of arrhythmia we're trying to make sure of. Now, you can see if it's big enough on an EKG. Okay, it is called the McGinn-White sign. I'm assuming because those are the guys that figured it out. So it's also called the S1Q3T3 sign. And that's because in S1, so you have a large S wave in lead 1. Okay. Then the Q, you have a Q wave present, because normally Q waves aren't supposed to be present, prominent Q waves, and that will be present in lead 3. Then you have a T wave inversion, and that's also present in lead 3. So you have an S wave, a really large S wave in lead 1. You have a Q wave present in lead 3, and T wave inversion in lead 3 as well. And that's it.